Good morning, respected Emeritus Chairperson Dr. M.L. Swankar sir, my respected teachers, dear friends and dear students. On the behalf of Department of Medical Oncology, I welcome all for today's CCR, and today we will discuss a case of metastatic squamous cell carcinoma who survived beyond the expected outcome of this patient. Before moving to the case, I will introduce my department and the work we are doing there in few slides. Then Dr. Raina will discuss the case forward. So this is our Shri Ram Cancer Center, which is the largest cancer center in the state, where we have all the facilities under one roof. The department was established in 2016 with one consultant, and the number of consultant and work is increasing year by year. On the left side of Swankar sir, you can see Dr. Priyanka Chaudhary, who is the recent addition to our department. He completed her DM in medical oncology from our department, and she recently joined us as assistant professor. This picture reflects the happiness index of our department faculty, and it is high, and it is high because we have strong backup of the specialties and super specialties, including radiation oncology, surgical oncology, pain palliative medicine. We have nuclear medicine, we have psycho-oncology, hemato-oncology, clinical hematology, and on the other side you can see the departments who are available to us on one phone call when we need them. Clinical hematology department is our brother department. Why brother department? Because Dr. Naveen and me are working together for many years since my DM residency. Then after MD from SMS, we did DM from AIMS parallelly. Then we joined the institute at the same time, and we are sharing our wards and stem cell transplant unit where we work together. We are the first in Rajasthan who started DM program, and these are our residents. You can see we have 2 seats per year. These are our 4 residents, 2 students. They opted the seats. They will join us soon as first year resident. These are the batches who has passed, and they are working at different places in the country, highly prestigious institutes. This is our OPD load, and it is increasing year by year. This is IPD patient load. We have 2 daycares where more than 150 patients are receiving chemotherapy daily. And this is hospital-based cancer registry. We have a MOU with ICMR. We upload our data of cancer patients. Each and every cancer patient with staging is uploaded on this portal, and we are getting 8 lakh rupees funding from ICMR per annum for this. We are among the few centers who have MOU with ICMR for that. We have stem cell facility at 6th floor in Hematology Tower, and we have successfully completed 122 patients of malignant as well as non-malignant condition. You can see the indications here. We have done autologous, allogenic, and matched unrelated allogenic transplant and haploidentical allogenic transplant, which are considered as critical and complicated procedure, and are done at the few centers in India. This is our clinical trial division where we do research, and these are the studies which are ongoing for different indications, including breast cancer, lung cancer, ovarian cancer. These are the publications. in 2025. This, in red, these are the publications which were done in 25 and 26. Recently, we published a book on early breast cancer, which was appreciated by many of our colleagues and students. NEJM is a prestigious journal, and fortunately, this article was published last month in NEJM. These are the awards obtained by faculty in last 1 year, and this slide shows the achievement of our residents who represent our institute in the different conferences at national and international level, and this is the list of prizes and awards they achieved in last 1 year. Preventive aspect is very important for cancer, and you might have seen this bus when you enter from the gate number 3 of institute, and with this we regular go to the community and we organizing awareness camps and screening camps for the public, and we have detected 5 patients till date who were asymptomatic for disease, but they were diagnosed at early stage and they were treated effectively. We know that early stage detection is very important for cancer patients. This is the guest faculty lecture list from national and international speakers. This shows the community awareness activities on different days. These are the conferences and workshops held in last 1 year, and last week we conducted this Immuno-Oncology Summit 2026, where different faculties from India has participated and appreciated. These are the academic activities held in year 25-26. We have different pediatric oncology ward at 8th floor hematology tower, and the goal is that no child should be denied cancer treatment irrespective of socio-economic status. The vision of future, we want to incorporate technology into patient care. We want the department paperless, and we want to accelerate the development of precision medicine like cellular therapy, including dendritic cell therapy, which is being done at our service floor by Dr. Anil Suri sir, cancer survivorship clinic, geriatric oncology clinic. These are the other goals. With this, I hand over to Dr. Raina for the case presentation. So, Dr. Raina, please. Because there was long journey of patient and there was involvement of different modalities, we have cut short the history part and examination part so that we can complete the presentation in time. Please pardon for that. Thank you.
Thank you, sir. Good morning, teachers, my dear colleagues, seniors. I am presenting the past history of 57-year-old patient who presented to us in April 2021. Patient is a known case of type 2 diabetes mellitus and hypothyroidism and is well controlled on treatment. He was a tobacco chewer since 30 years, 5 to 15 packets per day with no significant family history. Patient presented in April 2021 with large non-healing painful ulcer on inside of both cheeks for 5 months. Biopsy was done on both the sides, suggesting of moderately differentiated squamous cell carcinoma on both right and left. Further staging workup was done, both clinical and radiological, suggestive of clinical T3, N1, M0, stage 3 on the right side and clinical T3, M0, N0 on the left side. This is the TNM staging of head and neck cancer. The patient had ulcer of 5 cm, so falls in the category of T3. Patient had the node N1 and N0 on both left and right side, falls in the category of N0 and N1. and no distance metastasis with M0. So final stage 3 CT3N0/N1 M0. As surgery is the curative modality treatment in head and neck cancer, after discussing the case in multidisciplinary tumor board, patient was planned for definitive surgical resection. He underwent bilateral wide local excision with segmental mandibulectomy with right modified neck dissection on the right side and supraomohyoid neck dissection with microvascular free flap reconstruction on the left side on 22nd April 2021. These are the histopathological report post-surgery on both right side and the left side, suggesting of moderately differentiated squamous cell carcinoma. Depth of infiltration of 1 centimeter and lymphovascular invasion was present on the left buccal mucosa. Final staging was pathological T3, N0, M0 stage 3 on both the sides. Now we have a patient who has underwent definitive surgery with PT3, N0, M0. How should we proceed now? Question to the audience. Anyone? Correct. After surgery, there is high risk of recurrence in this patient. So, indication of adjuvant radiation therapy is lymphovascular invasion present, depth of invasion more than 5 mm, multicentric disease, and T3 staging. So, patient underwent adjuvant radiation therapy to bilateral face and neck from 9 June 2021 to 21 July 2021. Patient experienced few side effects related to radiation, grade 2 mucositis and grade 2 skin reaction. But overall patient tolerated radiotherapy well. Patient was on regular follow-up and after 5 months of completion of radiotherapy, patient presented again to us in December 2021 with ulcer at the primary site, loss of appetite, weight loss and body ache. On clinical examination, there was large ulceroproliferative lesion in right oral cavity, bilateral cervical lymph node, multiple painful subcutaneous deposit at multiple sites. So punch biopsy was done from the oral lesion and core needle biopsy was done from the subcutaneous nodule in the right posterior thigh. Also, whole body PET CT was requested. This is the MIP image showing the FDG uptake at the local site, cervical lymph node, metastasis at the lung site, multiple subcutaneous nodule and mets at the posterior thigh. We can see same in this picture, FDG uptake at the local site, mets at the lung, possible metastasis at the myocardium and metastasis at the posterior thigh. So punch biopsy was taken from the local site and core biopsy was taken from the thigh side. So it was suggestive of moderately differentiated squamous cell carcinoma from the oral lesion and metastatic squamous carcinoma from the thigh lesion. We came to a final diagnosis of recurrent and metastatic squamous cell carcinoma buccal mucosa. As it is a rapidly progressive disease and there was disease-free interval of less than 6 months, it suggests early systemic dissemination. What should we do next at this point when patient has presented to us with metastatic disease within 6 months? Anyone? As we know, patient has aggressive disease. Now our treatment option from curative has changed to palliative and only disease control and improved quality of life can be achieved at this stage. At this point, we have following treatment option: palliative chemotherapy plus targeted therapy, palliative chemotherapy plus immunotherapy, oral metronomic therapy and best supportive care. For considering immunotherapy as treatment option, we need PDL1, which is programmed death ligand Biomarker testing. PD-L1 expression was evaluated by immunohistochemistry, and now this is done in our house, in our institution, and we get the result within 48 hours. PD-L1 is a predictive marker. So higher the PD-L1 score, we can predict higher the response to the immunotherapy. And we can see the patient has PD-L1 CPS score of 95, so we can expect a good response to immunotherapy. Hence, we have chosen option 3, palliative chemotherapy and immunotherapy. Our choice of treatment is substantiated by NCCN guidelines. Immunotherapy and chemotherapy was chosen as treatment modality, which is the category 1 recommendation by NCCN. So patient received 6 cycles of chemotherapy and immunotherapy, and response assessment was done after 6 cycles, which showed complete metabolic response, as we can see in this slide. After 6 cycles, chemotherapy was stopped and patient was started on single agent immunotherapy pembrolizumab. After 24 months of single agent immunotherapy, patient was disease free as depicted in the last PET CT. Just to summarize the past history, patient presented to us in April 2021 with stage 3 bilateral buccal mucosa squamous cell carcinoma. He received definitive surgery followed by radiotherapy. In December 21, he presented to us with metastatic carcinoma and started on 6 cycle of chemotherapy plus immunotherapy followed by single agent immunotherapy. We continued immunotherapy till 24 months till December 2023, and then the treatments were stopped and patient was kept on observation. We did 3 monthly clinical assessment and 6 monthly PET CT. Total progression-free survival was almost 4 years, 47 months. And now in November 2025, patient again present to us for regular follow-up. So I invite Dr. Pranjjal Sindhu to take the case forward from now to what happens next.
Thank you, Dr. Raina. I will be taking the case forward. Patient is now 62 years. He came for his regular 3 monthly follow-up in November 2025. Patient was otherwise well, active with ECOG performance status of 0 to 1, but complained of mild headache. With these symptoms and regular PET CT was advised in November 2025, which was suggestive of single right temporo-occipital brain space occupying lesion with no metabolically active disease at any other site. Now I would like to invite Kaushiki Shukla, resident of nuclear medicine, to discuss about PET CT findings.
Thank you, Dr. Pranjjal. I'll be discussing the PET CT findings of this patient. This is the history we know till now. The patient was sent to us for 6 monthly follow-up. 18F FDG was injected IV and whole body PET scan was acquired. These are the MIP or maximum intensity projection images of the patient. On the right you can see the scan dated 9th March 2025, and next to it is the PET scan that was acquired on 28th November 25. The whole body PET scan shows physiological uptake at the brain, myocardium, liver, bilateral kidneys and urinary bladder with no appearance of any new FDG avid lesion at the primary site or any other site. Subsequently, brain PET was also acquired, and these are the MIP images of the brain. This is a 2D representation of a 3D scan compared to the scan done on 9th March. Appearance of a focal increased FDG uptake was noted at the right cerebral hemisphere. These small areas of tracer uptake are the physiological uptake of the extraocular muscles. These are the representative axial, sagittal and coronal images of brain PET CT showing FDG avid ring enhancing lesion in the right temporo-occipital region measuring 2.7 by 2.2 by 2.3 with an SUV max of 13.14. If we look at this lesion, it's a FDG avid ring enhancing lesion with irregular thickening and irregular FDG uptake, with area of maximum thickness showing the maximum FDG uptake. There is no obvious break in the ring with mild perilesional edema. So these were the final findings. Heterogeneously FDG avid, ring enhancing lesion in the right temporo-occipital cortex. Compared to previous scan, it was a new finding. These are the possible differentials, neoplastic and non-neoplastic. Because of the location of the lesion, the uniformity of the ring and the enhancement pattern of the lesion, neoplastic disease was more likely. Since all the brain metastases are not apparent on PET-CT, MRI brain was requested to look for other metastatic lesions and for better characterization. I would like to invite Dr. Abhijeet from Department of Radiology to take the discussion forward.
Thank you, Dr. Kaushiki. Good morning, respected teachers, seniors, and my dear colleagues. So the patient was presented to Department of Radiodiagnosis in view of high FDG uptake with vision. We did his MRI. These are the axial sections of T2 weighted and T2 flare images, where we can see a well-defined lobulated intraaxial lesion in the right temporo-occipital region with irregular margins at the gray-white matter junction, measuring approximately 27 in AP diameter and 20 in transverse diameter. The lesion appears heterogeneously hyperintense on T2 weighted image. These two images are of axial sections of diffusion weighted imaging and apparent diffusion coefficient, where we can see a bright spot in diffusion weighted imaging, which is corresponding to its ADC image, where we can see a low signal intensity focus. It denotes there is a peripheral diffusion restriction, which is suggestive of necrotic component, and these two images are of T1 post contrast, where we can see a thick irregular peripheral ring enhancement, and in the susceptibility weighted imaging, where we can see the black area in the lesion, which is the area of blooming, which is suggestive of hemorrhagic component. So we considered these differential diagnoses, first being the metastasis, high-grade glioma, fungal infection, and brain abscess. So to summarize the findings, the patient had a ring-enhancing intraaxial lesion with necrotic hemorrhagic component and peripheral diffusion restriction located at the gray-white matter junction in temporo-occipital region. These findings were raised the possibility of metastatic lesion. Thank you. Now I would like to call Dr. Pranjjal upon the stage to take the case forward.
Thank you, Abhijeet. Based on the clinical imaging findings, this case represents squamous cell carcinoma of bilateral buccal mucosa with solitary brain space occupying lesion. With this, we have two differential diagnoses. More likely is metastasis and infection. So for ruling out both the diagnoses, I would like to call Dr. Manavdeep Kaur to discuss about the neurological findings.
Thank you, Dr. Pranjjal. Good morning, respected dignitaries, my seniors and fellow colleagues. We got a referral for further diagnosis of the patient. As already discussed by the oncology department, the patient presented to us with subacute onset holocranial dull aching headache, which was mild in intensity, but not associated with nausea, vomiting, photophobia and phonophobia, with no focal neurological deficit, blurring of vision, diplopia and fever. As the patient presented with late onset subacute headache, the possibility of secondary headache was considered. On examination, patient is calm, coherent, oriented to time, place and person. His cranial nerve and motor and sensory examination was normal. There was no cerebellar signs and meningeal signs were absent. On routine PET scan by the oncology department, they suspected brain space occupying lesion, so MRI brain with contrast was done and was suggestive of necrotic hemorrhagic ring enhancing lesion in the right temporo-occipital region. So the possibility of brain metastasis, cerebral abscess and primary brain tumor was considered. The most common being the brain metastasis, as the patient is a known case of buccal mucosa with MRI suggestive of ring enhancing necrotic lesion with hemorrhages with lobulated margin and at temporo-occipital location, which is compatible with the hematogenous spread at gray-white junction. The next possibility of cerebral abscess was considered likely fungal, as patient is immunocompromised and the MRI is suggestive of hemorrhagic infarct-like lesion with necrosis, and the least possibility of glioblastoma was also considered. On further evaluation, we did a CSF analysis and pressure was raised to 30 cm of water with cells less than 5 and occasional lymphocytes. Protein and sugar were normal, thus ruling out the possibility of carcinomatosis, meningitis and other fungal or bacterial infection, as the bacterial and fungal panel and galactomannan level was also negative. It is crucial to differentiate the brain metastasis from fungal infection, as in brain metastasis there is vasogenic edema which is responsive to steroid, while in the fungal infection the steroids are harmful as they increase the infection. In brain metastasis, the patient usually is of any malignancy, with fever being the rare presentation, and on MRI the lesions are multiple in number with location at great white junction. On diffusion restriction present in the diffusion weighted images, and it is hyperintense on T2 images, with ring wall is thin, smooth, regular with nodular enhancement. While the fungal infection is usually in the patient who are immunocompromised, with fever being the most common symptom, and the number of lesions are either single or multiple with location at basal ganglia. On diffusion restriction are present at diffusion weighted images with hyperintense on T2 with variable edema, and the ring wall can be thick and irregular. We also did the workup for systemic infection, and toxoplasma antigen was sent, which was negative, and the urine sample for histoplasma antigen was also sent, which was within normal limit, thus ruling out the fungal infection. After evaluating the case, and our final working diagnosis is brain metastasis, but the gold standard is biopsy. After evaluating the case, the patient is referred back to Oncology department for the further management. Now I invite Dr. Pranjjal to take the case forward.
Thank you, Manavdeep. Based on the clinical history, PET-CT findings, CMRI brain reports, workup from Neurology department, and multidisciplinary tumor board was constituted, and for planning the management further. After discussing the case in MDT, patient was planned for surgery, considering the curative intent treatment if solitary brain metastasis is identified, and to get the tissue for histopathological examination. Now I invite Dr. Sahil from Neurology department to discuss about neurosurgical management of brain space occupying lesion.
Thank you, Dr. Pranjjal. Good morning, respected teachers, seniors and colleagues. As our working diagnosis is solitary right temporo-occipital space occupying lesion, surgery was advised, and right occipital craniotomy with gross total resection of tumor under image guidance was done on 18th of December 2025, and the intraoperative findings were that the tumor was localized in the right temporo-occipital region. Image guided resection was performed, gross total excision was achieved, and no intraoperative or post-op complications were reported. Patient was discharged on 21st of December 2025 without any complications and no neurological deficit. These are the pre-op and post-op image comparisons. As you can see in the post-op image, gross total resection was achieved without any hemorrhage, and no hemorrhage is seen. Furtherly, the resected specimen was sent for the histopath examination, and now I invite Dr. Himaxi to discuss about the histopath.
Thank you, Dr. Sahil. Good morning, all the respected teachers, seniors and my colleague. I'll discuss histopathological finding of the same case. We received specimen of right temporo-occipital SOL in our department, which consists of several grey white soft tissue pieces collectively measuring 3.5 into 3 into 1.2 centimeter. In microscopy, in first image, we can see glial tissue infiltrated by tumor. Second image is high power view of the tumor, in which pink fibrillary tissue is glial tissue infiltrated by nest and nodules of tumors, which consist of large polygonal cells having moderate pleomorphism, pale vesicular nuclei and conspicuous nucleoli. Third image is another high power view of the tumor in which we can see keratinization in terms of keratin pulp formation, which favor diagnosis of squamous cell carcinoma. Further, we applied IHC P40 coming strong nuclear positivity, which denotes squamous differentiation, and PDL1 tumor proportion score was 20 to 25%, which denotes linear plasma membrane staining, and combined positive score 30 to 35. So we gave impression of metastatic squamous cell carcinoma keratinizing type involving brain in a known case of carcinoma buccal mucosa, and PDL1 TPS was 20 to 25% and CPS 30 to 35. Thank you. Now I'll invite Dr. Pranjjal Sindhu to carry the case ahead.
Thank you, Dr. Himaxi. Post-surgery, patient was asymptomatic. However, despite complete macroscopic resection, there remains a significant risk of recurrence due to possible microscopic residual disease. Hence, the MDT was constituted and patient was discussed in MDT. And after discussion, patient was planned for adjuvant radiation to the post-op tumor bedside. Now I request Dr. Tanya Soni, resident from Radiation Oncology, to discuss about radiation oncology management.
Thank you, Dr. Pranjjal. I would like to continue the case forward. As presented in the history, post-craniotomy patient presented. They had two options, stereotactic radiotherapy or stereotactic radiotherapy surgery versus whole brain radiotherapy. So why do we choose SRS or SRT? Because it consists of safe delivery of ablative dose to the tumor volume, and small irradiated volume is irradiated, so the normal tissue tolerance is good, dose distribution advantage is there, and neurocognitive toxicity is lesser as compared to WBRT, which is whole brain radiotherapy. So SRS can be delivered by few of the methods, which consist of LINAC based system planning, which consists of CyberKnife, image guided radiotherapy, another is gamma knife, and the third is proton beam therapy. So we chose CyberKnife because of the advantages of it consists of robotic arm, extreme precision is there, so the normal tissue is not irradiated, it is less irradiated. Immobilization device is not rigid, so the patient has comfort. Real-time tracking of the tumor, if the tumor moves, the machine can track it, and the lower dose to organ at risk, that is minimal toxicity to the surrounding tissues. So planning process includes multiple steps, multidisciplinary processes involving CT or MRI fusion. Meticulous planning is done with the coordination of medical physicist and radiation oncologist team. This is a picture of CyberKnife that we have at our setup. Here I would like to thank other management team for providing such an equipped and advanced technique at our setup, and we have treated more than 100 patients till now with the CyberKnife. These are the contourings which we did for the organ at risk, that is organ at risk, and the constraints were achieved within the tolerance limit. So the planned dose was 24 gray in 3 fractions, which was delivered consecutively in 3 days. So here is a picture of SRS, which can be seen as a focal based tumor irradiation. The green one depicts gross tumor volume, which is receiving a dose of 100%. So patient tolerated SRS well and with no significant treatment related toxicities. Thank you. I would like to invite Dr. Pranjjal for continuing the case forward.
Thank you, Dr. Tanya. After completion of radiotherapy, patient was planned for systemic therapy. Given that patient had previously shown good response and durable response to immunotherapy, a decision was made to reinitiate immunotherapy as per the guidelines. The patient was started on injection nivolumab at dose of 3 mg per kg 2 weekly. He has received 4 cycles of immunotherapy so far, with last dose was given on 21st April 2026, which was yesterday. Patient is currently asymptomatic with minimal side effects. This reflects a good tolerability and continued benefit from immunotherapy re-challenge in this patient. In this slide, I describe the case summary. Patient presented to us in April 2021 with stage 3 bilateral buccal mucosa squamous cell carcinoma. At this time, he got definitive surgery followed by adjuvant radiotherapy. With a small disease-free interval of 5 months, patient relapsed with metastatic carcinoma in December 2021. Followed this, patient was given chemoimmunotherapy and later immunotherapy was continued till December 2023. In January 2024, patient was planned to be kept on observation, and till November 2025, patient was disease-free. The follow-up PET-CT, which was done in November 2025, was suggestive of solitary space-occupying lesion in right side temporo-occipital region. From this, we can say patient has a progression-free survival of almost 4 years, 2 years on treatment and 2 years on observation. The current status of the patient: in November 2025, the space-occupying lesion was addressed by gross total resection, followed by radiation to the tumor bed, and later planned for immunotherapy. Currently, patient is doing well with ECOG performance status of 0 to 1. He has received 4 cycles till date, last on 21st April 2026. From this, we can say that patient has total duration of treatment for last 5 years and he is still doing well. Now I invite Dr. Abhijeet Singh, Sir, Associate Professor from Medical Oncology, to discuss the immunological aspect further.
Thank you, Dr. Pranjjal, and very good morning to all of you. First of all, one question is there that why we selected this case for the CCR presentation. Because of we all know the head and neck cancer's natural course of disease is not likely that it's shown in this CCR. It is a very aggressive and very notorious disease with the median overall survival with previous chemotherapy and even after radical treatment, a very high chance of early recurrence and high morbidity and early risk of mortality, and the patient usually succumbed within 1 year with the help of only chemotherapy. So in this patient, the survival has been prolonged beyond the 5 years till date, and actually what survival is we expect with the chemotherapy and with immunotherapy, it is nearly 15 to 18 months only, but in few selected cases survival can be prolonged beyond years with the proper management including the MDT and the using of the newer advances in the treatment. So with this, I would like to briefly discuss about the head and neck cancer, and this is the Globocon 2022 data which suggestive of what happened in the world and what happened in India. So lung cancer is the most common cancer worldwide, followed by the breast cancer, and the lung cancer has high risk of mortality among the cancer related cases. But if we see in India the breast cancer is the most common malignancy, and lip and oral cavity subset of head and neck is the second most common malignancy. But if we see the cancer related mortality, the head and neck is a leading cause of that. So if we see the geographical variation in India of presentation of head and neck cancer, there is high to moderate age standardized incidence rate is found in the north and northeast and eastern part of the India, and majority of patients diagnosed with the locally advanced and late stages of the disease, which ultimately lead to reduce the survival of the patient. So what are the trends and changing pattern regarding the head and neck cancer? In the Western world, the incidence has been is in decreasing trend with the smoking related head and neck cancers, and increasing the incidence of oropharyngeal related or HPV related oropharyngeal carcinomas. But in India, the persistent high burden is there because of continuous use of tobacco chewing habits. So this is the survival by the stage. If we see in this stage 1, stage 1 and 2, the survival 5-year survival is between 60 to 90%. As stage advances, like stage 4C, that is a metastatic disease, survival is drop to 10 to 15% significantly. So this is the Kaplan-Meier curve of overall survival in the metastatic disease. We can see here the with chemotherapy alone, the median survival is nearly 7 to 8 months, with 5-year survival of less than 5% only. On adding immunotherapy and targeted therapy, the overall survival has been doubled. So this is the mechanism of action of immunotherapy. I am not going in the detail. I am just emphasizing the why PD-L1 testing is recommended before starting immunotherapy and how it works. We can see in the number 4, the PD-1 receptor is available on the T cells, present on the T cells, and the PD-L1 receptor is on the tumor cells. Whenever there is an interaction takes place in between these two, it is like we place a brake on the car. We place a foot on the brakes and the car is stopped. So whenever interaction between PD-1 and PD-L1 takes place, that T cells get dormant and not acts against the tumor cells. So by this concept, the role of immunotherapy has came by using the PD-1 inhibitor or PD-L1 inhibitors. That bricks can be released and the T cell gets activated, further release the cytokines and kill the tumor cells. Ultimately, formation of memory T cells takes place, which helps in the prolonged immune surveillance of for tumor cells. So this is the slide for immunotherapy toxicity and indications. However, the immunotherapy has been approved for across all solid tumors as well as hematological malignancy also. What we see in the clinics related side effects, there's a fatigue is the most common side effect, and other like skin toxicity and diarrhea, and the endocrine toxicity is also we found commonly. Otherwise, that end organ toxicity can happen, but it is very, very rare. So why immunotherapy is better? That improved OS in the many cancers, better quality of life, long lasting responses, effective in advanced and metastatic disease, lesser toxicity. So it is the immunotherapy is transforming cancer care from the short term control to long term survival with growing accessibility, shaping its future impact. The major hurdle is there that the financial barrier, which is the barrier. Because of that we are not able to use this higher molecule in each and every patients. In respect to this, the newer biosimilar molecule has been developed in the India. It has already been approved, which has already comparable efficacy, safety, and toxicity profile with major cost reduction and improved accessibility to the lower middle class also. So this is the summary of this table. Efficacy and safety of the original molecule with the biosimilar is comparable. Pembrolizumab was the strong first line evidence. Nivolumab versatile across all lines, and biosimilar, it is a game changer for affordability and access in India. So take home message from this today's CCR. India is a global hotspot for oral cavity cancers, and tobacco and alcohol is the multiplicative risk factors. Majority of patients present in the locally advanced stage with high rates of recurrence even after radical surgery with concurrent chemoradiotherapy. And the advent of immunotherapy, it is a major advances in the systemic therapy of head and neck cancer. And the selected patient have prolonged disease control with checkpoint inhibitors. So treatment individualization and the multidisciplinary treatment approach yield the best results. In some cases, multi-year survival is possible with optimal treatment, as like in this case. So with this, I would like to we are very grateful to the patient and his family for their trust, faith in our institution, our team, senior management, and hospital administration for providing us with all the facilities for optimal diagnosis and the treatment. Then CCR review committee, and I will also grateful to the Department of Surgical Oncology, Radiation Oncology, and other collaborative department who presented this case very nicely. With this, I am playing the testimonial video of patient's relatives, which he appreciated this.
और radiotherapy हुई, but unfortunately in December 2021 the cancer got relapsed, और फिर हमने डॉक्टर हेमंत सर के अंडर ट्रीटमेंट लेने का डिसीजन लिया, और उसके बाद हमारी मेरे फादर की कीमोथेरेपी और इम्यूनोथेरेपी हुई. The immunotherapy lasted for 2 years and there was a complete metabolic remission. In 2023 therapy was stopped, but unfortunately in December 2025 a small lump was found in the brain, and डॉक्टर B.S. शर्मा सर के अंडर वापस से एक सर्जिकल प्रोसीजर हुआ, और अभी आफ्टर सक्सेसफुल सर्जिकल प्रोसीजर हमने फिर से डॉक्टर हेमंत सर की गाइडेंस के अंदर ट्रीटमेंट कंटिन्यू करने का डिसीजन दिया है एंड द ट्रीटमेंट इज अंडरगोइंग नाउ. And for the entire guidance and the treatment, we are very thankful for the Mahatma Gandhi Hospital and also Dr. Hemant sir and his team for the entire guidance and support that he has provided during the treatment. Thanks a lot.
Thank you. With this, I completed this, and thank you all very much for your patience listening.